Well, welcome to the next session. We're live now with Dr. Craig Morrison, myself, Charlie DeCook. We are.
Thank you.
Hey, Craig, how are you?
I'm good, Charlie. How about yourself?
I'm super excited to be at Doc SF. We get to do it all the way from the South.
Yes,
they're all the way in San Francisco for this thing,
that's true. And I'm sure a lot of the docs out there are not working. So I'm guessing this thing's going to be well attended.
I had the chance to go this January to the live event. I'll tell you, Stefano's done a fantastic job. We're excited to be with you, and we wanted to thank Doc SF for having us. We especially wanted to thank DePuy for sponsoring this next 45 minutes. Craig and I are going to have the awesome opportunity to talk to everyone today about outpatient surgery and, frankly, COVID's effect on outpatient surgery. So I think with that, Craig, unless you have any intro comments, I'm going to jump into my presentation.
Now, share some wisdom, Charlie. Looking forward to it.
Sharing away. Hopefully everybody can hear me. So the title of our session is The Better Normal, and we're going to give you an idea of why we call that the better normal. Again, thanks to DePuy for sponsoring us. These are my disclosures. Craig will show his. We've often talked about the new normal. In fact, I'm sure you heard that today, and we all have visions of what that new normal is going to look like, the social distancing associated with it. But really what it's implying is that, we're kind of forced to live this new life that we didn't really want, right? And COVID has kind of forced us into this new normal. I think that's the wrong mentality to have with this process. There's a great guy named Elder Dieter Uchtdorf who said, it is your reaction to adversity, not the adversity itself, that determines how your life story will develop. Craig, that's what I want to talk about today, is how we react to this adversity and what that means in terms of outpatient joints. So from my perspective, it's up to us how we react to COVID. It's a conscious decision for us to learn and to become better. That's it. So that's why we've topicked and called this the better normal, right? And for one of those things, I think a lot of you can relate with, I have never had so many dinners with my family in my life. I mean, I've had a chance to introduce myself to my kids again. They know who their father is. I mean, it's been a fantastic thing for me. So in some respects, I will tell you, it has been a good thing for my family and those around me. I'm going to give you lots of recommendations on books to read during this 45-minute session. The first one you have to consider is Clayton Christensen's How You Will Measure Your Life. And Clayton, for those of you who don't know, was at Harvard. He unfortunately passed away earlier this year. I had an opportunity to take one of his courses. But really what Clayton Christensen taught us is the job to do. And that is, we all have jobs that arise in our lives, right? And some of it's taking our kids to school or eating or going to work, right? Those are jobs that arise in our lives. And frankly, we hire products in our lives to get that job done. So COVID absolutely changed our life, okay? But ultimately, we are controlling our reaction to that, and it did not fundamentally change the job. And what do I mean by that? I mean that the job really fundamentally never changes. So if you think about Julius Caesar, his job was to transport, right? Abraham Lincoln, Henry Ford, Elon Musk, all looked at transportation, that job of going from point A to point B. They all looked at it differently, but it's all the same job, right? So if you think about how our job has changed, we're still schooling our children, although it may be at home now. We are maybe not eating out with our friends right now. We're in some strange grocery stores with masks on. The job is still the same, right? It looks different, right? I'm not in San Francisco. Craig is still hanging out in Nashville. But the job is still there, and that's the most important thing, even though it looks different to us, right? The most important thing I want us to get from this is that we have to better understand the patient's job to be done.
Understand what it is the customer is trying to accomplish. What's the job that the customer is trying to get done?
What's the job?
Here are the things that most patients need, which is, would you please diagnose what's wrong? And would you please reliably fix this problem?
That's the most simple way to really think about what our patients need from us, right? Tell me what's wrong. How do I fix my problem, right? So COVID has taught me a lot of things that I've mentioned. Another thing that's interesting is kind of the similarity between COVID and, hold on for this, Craig, I know this is a tough one, self-driving cars, right? So what's the relationship? It's something called Bayes' theorem. So I'm going to get into that. So when you think about when you jump in one of these driverless cars, what's happening is this technology is having to ask, where are we right now, right? So something called SLAM is how this technology works for self-driving cars, and that's simultaneous localizing and mapping. And what it's basically asking every second is, where am I at right now? That's the real beauty behind it, and that's all based on conditional probability, based on Bayes' theorem or Bayes' law. And the idea is that there's a prior belief, and the very next second we could have new evidence and change our belief, right? So how has COVID changed this for us? A belief is nothing more than acceptance that a statement is true or something that exists. So if you think about it, with Bayes' theorem, we have a personal belief, and we have new evidence that's going to change that, give us a new belief. And I want you to think about, for all the surgeons in this room and for all those who are developing technologies, how has COVID changed our perception of the patient's job to do? You know, ultimately what it's taught me is that we have to create new products, new services that enable patients to get their job done better. And to do that, we have to better understand that job. Winston Churchill is one of my favorite historical figures. He said, courage is what it takes to stand up and speak. Courage is also what it takes to sit down and listen. And unfortunately, a lot of us surgeons listening in today have been doing a lot of this sitting down and listening because frankly, our ORs have been empty and we've got nothing better to do than to shut up and listen. So the question is, what is COVID really telling us?
Peruse some of the faces from the past. You've walked past them many times. I don't think you've really looked at them.
Craig is my favorite movie of all time, by the way.
It's based on a school in Nashville.
I didn't know that.
They're not that different from you, are they? Same haircuts, full of hormones, just like you. Invincible, just like you feel. The world is their oyster. They believe they're destined for great things, just like many of you. Their eyes are full of hope, just like you. Did they wait until it was too late to make from their lives even one iota of what they were capable? Because you see, gentlemen, these boys are now fertilizing daffodils.
This is a great one. Obviously, these are pictures that were from the 1918 influenza pandemic, but previous generations have gone through what we've gone through, right? And the question is, how do you look at it differently? How can we look at COVID differently than we did influenza? A great Harvard doc, Dr. Pasquale Leone, did this, and that is, he did a study on Braille. He took sighted individuals and tried to teach them Braille. The unique thing about his study was he blindfolded all these people and did functional MRIs. And lo and behold, by day 5, with these blindfolds on, all of a sudden, when you're trying to read Braille, your visual cortex lit up. Fascinating, isn't it? So it basically implied that by blinding us in some way, it allows our other senses to start picking up more. So what has COVID done for us? And I'll play this video from Steve Jobs.
There's an old Wayne Gretzky quote that I love. I skate to where the puck is going to be, not where it has been.
So where is it all going? So it's going exactly where we said, to help patients get the job done better. And that means it's faster for the patient, it's easier and better and bringing more value.
The 3 big ideas are low prices, fast delivery, and vast selection.
So Jeff Bezos had it right with Amazon. Why can't we apply those same basic principles as we consider the patient's job to be done?
The central guiding principle that has to be true north in every choice we make about that needs to be value for the patient.
Value for the patient, Michael Porter there. So tell me what is wrong. That's really saying, what's the diagnosis and how am I going to fix it, or what's the treatment, right? So when we think about the diagnosis over time, right, Hippocrates brought our profession out, right, and brought it to us, and then we started to go to cadaver labs back in the 1500s. We started learning that, hey, these diseases actually exist. It may not just all be God's creation. This may be actually diseases that are happening. And pathology started to happen. And we started to learn how to do a physical exam in the 1700s. And discovered the stethoscope in the 1800s and the ophthalmoscope. And Henry Koch decided to start using a microscope and finally a thermometer. We're using all these diagnostic tools to help us better diagnose, right? The blood pressure started to be developed right before 1900. And of course, all the orthopedic surgeons in the room, very familiar with Roentgen and his discovery of the radiograph, right? But of course, you've got echocardiograms and the first CT scan, MRI, all cool innovations that helped us be better, right? And that's what we as physicians want to do. We still want to be better. And Atul Gawande says this better than anyone else.
I come to you as someone who has been really interested in how I get better at what I do and how we all do. I think it's not just how good you are now. I think it's how good you're going to be that really matters.
So that's ultimately what we want to do as physicians. We want to continue to be better, right? We want to diagnose better, but not only do we want to be better, now we have to start thinking about it from a patient perspective. I not only have to give the right diagnosis, but I have to give it faster than I ever have before. I have to deliver it cheaper, easier for the patient. Those are the things we have to start thinking about. Same with the treatment, right? We've always been stuck in these hospitals, right? This hospital model where I have an OR next to a pre-op area, next to a floor where patients can hang out for a few days, right? This hospital model has been with us for a long time, and we think of some of the greats out there, John Hopkins. Why do we keep people in the hospital? Well, frankly, we were afraid they were going to die. Why do we round on patients, right? We learned all these great things from hospitals, right? So if you look at John Charnley, the first successful hip that was performed, done in a hospital, we've been so accustomed to the hospital model. But this is what it gets, right? So it gets us this.
During the first 3 or 4 days, the patient remains on simple skin traction, but the weights are removed for active assisted exercises. Walking is encouraged after a week, at first with the aid of a frame. Most patients leave hospital between 2 and 3 weeks after the operation has been performed.
Craig, this is how they do it in San Francisco.
I doubt it. I doubt it.
Just kidding. They're ahead of the times, right? But unfortunately, we are still in the same hospital institutions, right? The same constraints of outdated processes, staffing, and cultures. And believe it or not, in 2020, this is a random video I found on YouTube, right? We're still standing in front of a whiteboard. Why is it in 2020 that I still rely on a whiteboard? I took a picture the other day just to show all the staff sitting around in my OR with the head nurse sitting there in front of a whiteboard. You know, it's no wonder the logistics is so screwed up in our hospitals today. So imagine with me, you know, obviously I'm in Atlanta. It used to be where Delta had a hub. I don't know if they have a hub here anymore with COVID. But can you imagine trying to deal with all these flights, trying to use a whiteboard? Craig, I don't know if you guys still have a whiteboard, but in Atlanta, nope. I mean, you're out. You're all the way.
Whiteboard. Digital.
I love
it's the wave of the future, Charlie.
It's the future. If you think about it, though, a hospital is no different than an airport and dealing with logistics associated with it instead of relying on old things, right? And it's no wonder that the majority of us surgeons get frustrated right now because this is what our OR day looks like. We hang out in the locker room or, you know, eating in between cases because, frankly, we're not operating, right? We prefer to be in the operating room. You know, and you think about applying these problems of logistics. Henry Ford figured out quite well, and he said that what was worked out at Ford was the practice of moving the work from one worker to another until it became a complete unit. That's what we haven't seen at hospitals, and as a result, we're working at a status quo of efficiency of 50%. I mean, we want to be operating more, and I equate this more to like a combustion motor, right? That operates at 28%, right? It ultimately has met our demand ever since Henry Ford came out with the Model T. It's worked for us, but that demand is going to change, right? Just like our hospitals in a post-COVID world, that demand is going to change. We're going to have to improve our efficiencies. This is a great thing. I don't know if you know much about Uber Elevate, Craig, but Uber Elevate is this great, cool, futuristic way of looking at electric vertical takeoff and landing machines. Can we have these drone type devices that will allow us to transport ourselves, but it's going to require us to have much better efficiency than we ever had before. And I think absolutely our operating rooms today have to be much more efficient in order for us to true value. Value is absolutely best described by Michael Porter.
Why is value the problem? Value is the problem because only by improving the value can we actually solve the problem, which is that healthcare systems are just spinning out of control all over the world.
So I think we felt that, and I think this is the exciting thing we're talking about today, Craig, which is finally getting out of hospitals, going to this ASCs, doing outpatient total joints. This is the exciting thing. And I think with that, I'm gonna end my slides, if you guys don't mind hiding my slides, and we're gonna open up Craig's slides here. And I'm going to listen to Dr. Morrison tell us all about outpatient joints in Nashville.
Thanks, Charlie. As my slides are coming up, fascinating talk. We learned about a lot of history, and we learned how automated cars work, which I did not know that. I'm sure a lot of audience in San Francisco knows that. But I also learned that your talks are so interesting and have so much because of the Harvard connection. I myself went to Baylor, so I'm going to be bringing it down, a little bit more ground level. Not going to get much of a history lesson other than my own history. And I want to talk a little bit about how I think coronavirus has sort of changed the conversation about outpatient joint replacement with our patients and also with our colleagues. These are my disclosures. I am getting an honorarium, and I'm thankful that DePuy Synthes is sponsoring this segment. But there isn't anything in here about their technology or their implants to be biased by. It's no surprise, I don't think, from anybody. Charlie was at the very beginning of this curve. He was doing it when not many people were doing it. But even pre-COVID, it was very clear that if you weren't in outpatient arthroplasty, if you weren't even thinking about it, you were probably behind. It was looking like before 2030, even sort of in the mid 2020s, that up to 50%, maybe even more, joint arthroplasty would be done in an outpatient setting. So it was already happening even pre-COVID, and I think you needed to be in that. I'm sure that a lot of the audience is in that, but if you're thinking about dipping your toe into outpatient arthroplasty, I think the first question you have to ask yourself is, what is the right venue for you? You can do outpatient surgery from the hospital, but you also know traditionally that you can do it from an ambulatory surgery center. There's pros and cons to both. In the hospital venue, I think it's probably the most comfortable place for surgeons to start. You can use your normal protocols. You can select patients that you think may be good to be able to go home. They qualify to go home. But if you miss the mark, if something doesn't go just quite right with the protocol, or if the patient becomes anxious, or the spouse or family member becomes anxious, there's always that safety net right there where they can spend the night. I think it's also true that you have the luxury in most hospitals of having specialist care there, so that if something goes wrong, it's right there. It's not stressful. You call for a consult. And it's familiar to the patient and to the surgeon. I mean, Charlie pointed out, if you look at how joint replacement and all medical care has been done, it's always about the hospital. Even with its shortcomings, it's what's familiar when you're first starting out. And I would also say that definitely pre-COVID, it was the patient's perception that of the two venues, this was the safest place to do it, the best place to have your surgery, whether you're going home the same day or not. Of course, the other venue is the ambulatory surgery center, sports, hand, upper extremity. Most orthopedic surgeons have been very familiar with surgery centers for years, but not so much arthroplasty surgeons until the last few years. What you see there is more pressure to send the patient home, unless you have the ability to keep them 23 hours, which a lot of surgery centers don't. And because of that pressure, a lot more pressure around appropriate patient selection. Less familiar, especially for arthroplasty surgeons, but certainly a big pro is the financial incentive, the ability to have ownership in it, but also the ability to have some say in the management of a surgery center, way more than you would in a hospital. And I would say that pre-COVID, patient anxiety was probably a little bit higher for a big joint replacement surgery, initially in a surgery center. But I think that conversation maybe has changed a little bit. I think the ASC is the way to go. I know that Charlie agrees with me there, because surgeons do not, like Churchill said, have to sit down and listen. They can be a little bit more opinionated and boisterous and have some say in how things go. If you are thinking about a surgery center, what you need to think about are whether you want a partner, whether you want to go in just with all orthopedic surgeons, full ownership, manage the whole thing yourself, or whether you want a partnership like a management firm, or more often a hospital partner. Certainly, just like the venue, there's pros and cons there. I think the pros of working with a hospital system is that they can handle the management and you can handle what you are good at, unless you are very business savvy like Charlie. They have contracting that's typically better. Many times, not all the time, but many times they have better relationships with the vendors to be able to lower the price. And so that can be, sort of the easy button or turnkey solution if you have a hospital partner. You do need to know what your state's certificate of need laws are, because you may not have a choice. Tennessee is a certificate of need state, and it's extremely difficult to get a surgery center without a hospital partner, because apparently need means the hospital doesn't need someone competing against them. So they do not let those go through. And you do have to remember that your cases are your leverage. So as you're doing more and more cases, I think you need to experiment doing outpatient in the hospital. Fortunately, in most markets, there are competitive hospital systems, and if your hospital is not interested in the surgery center with you, you can use your cases and walk down the street to get a little bit of leverage. This is the CON map, the most recent one. You can see that not only is Tennessee a CON state, but it is surrounded by CON states. So as our group was looking into surgery centers, we couldn't even go across the border to another state to get a surgery center. So we needed to play ball at the hospital, and initially they were not interested. Fortunately, a bit out of town, under the radar, some surgeons many years ago were able to get a surgery center without a certificate of, or they got a certificate of need, but without a hospital partner. And about 2 years ago, they were able to get joint contracts with some of the commercial payers. They invited us to do cases there, which we definitely stood up and said, please me. And it didn't take very long to take those cases to that surgery center before the hospital was more interested in having a surgery center with us. And so now we have a partnership with the local hospital. This used to be sort of my screening question for whether or not I thought a patient could be a good candidate for outpatient surgery. I kind of agree with Charlie in his practice that you almost have to look for the exception to not be an outpatient candidate rather than the rule. And so for me, the big thing was the anxiety. So if I started talking surgery to a patient and would say, I think you'd be a good candidate to go home the same day of surgery. If I got this, then the conversation shifted quickly back to, but you can also stay in the hospital, and we fell back into the old familiar thing. If their eyes didn't bug out, or their family member or spouse's eyes didn't bug out, then usually the conversation went something like this. Well, where do you do surgery? Where would I have my surgery? And my answer, in full transparency, was always, well, I operate at the hospital, or I operate at a surgery center out of town. You can go home from either one. And before you can really get into the pros and cons of either one, the response usually was, well, I'm already here at the hospital. I know where it is. It's familiar. And if something happens, I'm here and it'll be safer. So oftentimes, even the outpatient candidate chose to go to the hospital. But I think that conversation is changing because of COVID. In Tennessee, we've been back seeing patients in clinic now for 3 weeks. We did telehealth before that. Never done telehealth before, but it's definitely going to stick in my practice. And what I've seen just in that short time is that patients are asking for outpatient surgery, or if it's an option for them, before I even bring it up. And when it is brought up, they typically are more interested in the ASC. So that paradigm before of the hospital is the safest place for me to have my surgery is kind of shifted to, if I can do this outside of the hospital, that's actually the safest place. And as we all know in our practice, success begets more success. It's the patient that has a great outcome that brings you more patients. Word of mouth is king. That's how you get more patients. And as I think about this outpatient paradigm changing, this ASC paradigm changing in my practice, I look back on what discharge disposition was like when I first started in practice. I started in 2002, and even 3 years into practice, almost all my patients went to an inpatient facility after the hospital. 3-day stay, inpatient facility. It was how we always did it. It's how my partners did it. That was just how it was. And when patients came into our group, it was almost the assumption, my spouse went to rehab, had an aunt, a friend that went to rehab, so I'm going to rehab. So through the years working to decrease that, about 5 years later, it was down to about 50%. And as bundles came in, which I'm sure most of you are involved in some form or fashion, or at least heard about it, that utilization has come down now to less than 10%. So now there is not that expectation when a new patient sees me, they're going to have surgery, they're going to be in the hospital, that they're going to go to an inpatient facility afterwards. So that word of mouth is, you're going to go home. If you see Dr. Morrison have surgery, you're going home, even if you stay in the hospital. I feel like that same thing will happen with outpatient surgery. I didn't do my first outpatient surgery until 2014. That was from the hospital. And from there, it was, a case here or there, only if a patient asked for it. It wasn't until 2 years ago that I did a joint in an ASC. And already a year later, almost 20% of my cases are outpatient, albeit because of that conversation with patients. Many of them are from the hospital. But now that I'm seeing that conversation change because of Corona, I think that 2020, the rest of the year, I'll be doing a lot more cases in the ASC. And I think next year, because those patients will go out and say what a good experience they had, they did well, that within a few years, that will be the norm or the expectation when a patient comes in, that they're assuming they're having their outpatient joint done in a surgery center. So kind of to summarize, I think that there's no question that it is on the rise. We saw it was on the rise before, and it will still be on the rise after COVID. My personal opinion is that a surgery center is the best venue to do this, because the surgeon not only has financial incentive, but you have a voice. You are able to control the protocols. You're able to control the management. And for the care of the patient, I think all of us would agree, if we have a bigger voice, the patients are going to have a better experience and a better value, as Charlie talked about. Make sure you understand what kind of partner you want, pros and cons of each, and what your CON laws are. I can say that in my short experience back working, since COVID shut us down, that patients are very open to ASC as a venue for their surgery. And I do think that that graph I showed where it was rising up to 51% by 2026 is actually going to grow faster and a little bit steeper than that because of COVID. Thank you. I appreciate your time. Hope y'all have gotten some out of this. And I think Charlie and I have a little bit of time to stick around and hopefully answer some questions. Thank you.
Greg, fantastic job. We've been getting a ton of questions coming in. Your talk has prompted all kinds of great questions. I think my first question for you is just kind of a practical one, and that is, what are your patients saying about COVID? What's the patient perspective in Tennessee? I know we're not in California, we're not in New York. Give us an idea in Tennessee right now. What are patients saying? What is that doing with your numbers?
Well, it's obviously very regional, and I would say that their thoughts on COVID probably mimic what they hear and see the government opening up a little bit earlier here. With very few exceptions, the question that patients ask is, how soon can I get my surgery done? Not, how are you going to protect me from coronavirus? It's almost a default assumption that we're going to protect them. I think that says a lot about the healthcare, that they know that we're looking in their best interest. My response is typically that hospital is the safest place you can be right now. It's better than the grocery store because you have to wear a mask. People get their temperature checked. But the surgery center is probably even safer because it's been shut down for 6 weeks. And so nobody's been there.
Give us an idea. I think that's a great point. I had that thought the other day, which is, man, this is a safe place I'm in. Everyone has to be tested to be in there. So at least from my perspective, give me an idea of how are you guys handling testing? Is it mandatory? Is it not? Give us an idea.
Well, just like a lot of hospitals had a big task force before coming back about how are we gonna do this. The reality is, testing is not up to speed anywhere. It's not super accurate. Certainly the point of care testing where you get an hour turnaround is not accurate at all. So the concept of testing a patient days in advance for them to come in would not change how our anesthesiologist approached that patient. You almost have to assume that they're positive unless you get a point of care test, which you can't do for everybody. So we're not testing anybody. If you have symptoms, your surgery's delayed for 2 weeks. And they get screened when they schedule surgery, they get screened when they pre-op, and then they get screened again when they come into the hospital. So logically, the concept of testing everybody other than the day of surgery just didn't pass muster for our group.
I'm super, super jealous. So our hospital mandated that every patient having a surgery get the test. In fact, they will delay all surgeries unless they get the test. And I argued your exact point, which is, hey, listen, we're taking universal precautions here, right? It's much like blood and HIV was, right? We're taking some universal precautions. Why is it that we have to test? I think the only thing that made sense to me was if you happen to just started the virus, we happen to operate on you, and 3 or 4 days later you start getting sick or other things like that. I think that is a rational way of thinking about why we would do some testing. We are doing a 3-day test. We agree with you. At least our point of care testing sucks as well. There was a big fervor for having these antibody tests, but frankly, I have no idea what I would do with an antibody test, right? I mean, I'm an orthopedic surgeon. I frankly don't even know how to use the stethoscope, let alone kind of interpret an antibody test for COVID. So it's interesting to hear. And of course, we've talked to surgeons around the country, and it's all over the place in terms of testing. I want to get back into outpatient. Give me an idea. This is DocSF, and this is the leading institution in getting us to think outside the box, getting us to think digitally about things. What is it, do you think, from a digital perspective, has helped you transition to outpatient joints? Is there anything you're utilizing today that says, man, I have to have this to do outpatient joints?
Yeah, I would say the first transition was into the hip world. The anterior hips is probably where I did.
Somebody kick Craig off here. This may be quite an interesting session without Craig. I will, while Craig's waiting to reconnect, I will answer my own question, which is, what technologies have helped me? And the honest answer is you really do not need any specific technology to get you to do outpatient, right? It's just going through protocols, going through interacting with the nurses, the anesthesiologists. That's the most important thing. I will say that what is different between outpatient and inpatient is this, and that is, it's so important that we prepare patients better, right? The model in the hospital is we take a short period of time to get someone ready for surgery, we do their surgery, and there's a prolonged recovery process. That has to change in the ASC world. We have to take that process of getting someone ready and really extend it. Make sure they know everything about their surgery, what to do with their dressing, who's going to help take them home, who's going to help them up and down the stairs, right? So devil's in the details when we're talking about outpatients. So I spend a ton of time, money, staff getting those patients ready. And what better way to do that than with a technology, digital technologies to do that, right? Because frankly, I don't have the bandwidth to go through with each patient all these things that I want them to prepare for their surgery. How much better it is if we utilize a technology to do that, to automate that process, right? So I happen to use a program called Force. So Force is one that we've used. I'm sure there's several out there. We've been super happy with the interaction between patients and Force. Craig, glad to see you're back on. It's amazing how much.
I thought you left.
I could talk to myself for hours. So we were just talking about Force, which is an application that basically interacts with the patient both before surgery and after surgery. Again, not mandatory to do outpatient, but for us has been helpful. I'll turn it back over to you, Craig. Any other technologies helping you in that transition outpatient?
The biggest thing has just been keeping up with data and patient outcomes. We got the screening tools looking at whether patients are going to be good, and it's the things that we have found that are the most helpful are less about health questions and more about social questions and their home environment. The reality is a healthy 80-year-old can definitely have an outpatient hip replacement, but if they live alone and they have 4 flights of stairs, it's probably not the best thing for them. So you got to make sure you really dig into their social situation. And sometimes it's in their best interest to delay their surgery until they can get a little bit of social support to keep them from having to go to a facility.
Craig, I think that is the best point that we're going to have this whole session. Social support, I'm going to support what Craig's saying 100%. You look at AFib, history of DVT or coronary artery disease, obesity, obstructive sleep apnea. You think about all these different things we think of, maybe that's a contraindication to do outpatient. The number 1, the number 10, the number 100 is social support, right? So my very first question when I see a patient is, who's going to take care of you after surgery? And, it's interesting. A lot of people will hesitate or say, I don't have anyone. That's kind of a lot of people's response. And I think it's because they don't want to be a burden on other people.
Right.
If you live in New York City, it may be true that you don't have anybody. It's funny. Some of the guys at HSS yeah, actually true. They actually may not have anybody. Well, at least in the state of Georgia, I don't want to generalize too much, but the vast majority of people, if you ask them, there's a neighbor or a relative. The interesting thing is, you often ask them, oh yeah, my daughter lives 30 minutes away, but she's not going to be able to. I just don't accept that. I enable them to make the choice themselves. So they have to choose a caregiver that's going to take care of them afterwards. I don't know how you guys do it, Craig, but how do you manage that social support?
Yeah, we still do the same education if they're going outpatient. There's a class that they can either come to or be digital, but we spend a lot of time talking about a coach. So everybody has to have their own coach that's got to be involved and come to the education. So they kind of have to designate someone that is with them. Now you get the bait and switch sometimes where, my coach didn't come and now I got to stay in the hospital. But that's pretty rare. If you repeat the same thing, the same message over and over again before surgery, and everybody on your team repeats that same message, it usually goes pretty well.
Oh, that's a fantastic
logistical question for you. It's selfish, but maybe someone will get something out of it. So you do a high volume in your surgery center, several cases a day, and I'm sure you don't have the sterile processing that the hospital has. So how can you move through several joints in one day without relying on instrument turnover? You using disposables, or do they just bring in several sets? How does that work for you?
That's a great point. The logistics of dealing with bringing them to a current ASC, a lot of us had to join ASCs that are frankly occupied by hand surgeons or sports docs. They got all kinds of scopes, but they got no room to put, 7 trays for my total knee. Great point. We made a point when we built our center to make sure we had enough sterilizers, enough room for all these darn instruments we use. So for us, the physical space is not much of an issue, but I will tell you we have transitioned to using what DePuy calls a solo, but it's just disposables, 2 trays for total knees. And what that allows us to do is instead of spending 19 to 23 minutes opening 6 trays for a total knee, I can open them in under 2 minutes, right? So either myself or my scrub tech is going to open everything I need in 2 minutes, right? So from my standpoint, it's not a physical space, it's a time thing, you know, because I want to bounce it back and forth between rooms. I want to do a ton of cases, and I want to drive true value. And to do that, I need everyone to be efficient. So for me, these disposable instruments have been key for that.
Have you gone to small sets in terms of sizing, like for a knee? You know, you've only got 3, 4, and 5 in one set, and 6, 7, and 8 in another set. Have you been able to decrease the amount of sizing capability?
We're working to that. The problem is that what a lot of surgeons do is they'll take those 6 sets, throw them into 2 sets, and they'll do dump pans, right? So they'll take them and just throw them in a dump pan. The problem is the sterilizing issues with that is a big issue. We did that for a period of time before we really realized that to sterilize, it has to be neatly placed on a nice tray. Not a lot of vendors yet have that ability to cone down to a 3, 4, 5 knee, right?
Yeah.
You know, ideally that's where it's going. It just-in-time implant, just-in-time instruments. That's where it's going. I think it's pretty easy for us to be able to size these things, especially with hips. With knees, of course, less of us do templating. It's interesting. I have a fantastic scrub tech. I do a 2 knee, happen to do a 2 knee, and my scrub tech grabs the foot and will tell me 95% of the time what size I am before I even start the case.
You should validate that.
Yeah, it has been. Foot size has been a pretty easily validated way.
Yeah, it looks like someone asked a question kind of along those lines, like how do we feel about single-use instruments, or you've probably seen the single-use reamers for hips. Have you seen that? And is that capable in ASC? Do you think that there's an extra cost to those things, but do you think the savings on the backside is worth doing some of that stuff?
It's tricky because in hospitals, you know, you can say, well, it costs, I don't know, let's say $100 to sterilize, blue wrap, and all the rest. But in an ASC where you own everything, I mean, it just costs me the cost of electricity, right? And a little bit of washing fluid to, you know, to basically turn over a tray, and the cost of, frankly, a $13 an hour staff member to clean all those trays. So from my standpoint, cost is not as much the issue. It's efficiency, it's time. That to me is more valuable than the savings from doing an extra blue wrap or something like that. I will say these disposable reamers, although I've tried them a lot in cadaver labs and over the last 18 months, I think that's a cool, exciting way to do it because we're pretty darn good at sizing our cups, right? We can tell within 1 or 2 reamers. I try and ream once and sometimes twice. So for me, that will work well once a good option is out there for me.
So what do you think your percentage of ASC cases are right now of your total joint volume? You probably know exactly.
Yeah, well, we do about 98% outpatient joints in the hospital or ASC. Right now, our number as of January was around 35%. That's just because private contracts and the rest is Medicare. When it flipped with Medicare knees, we're doing the vast majority of Medicare knees in the ASC now. And that has definitely bumped up above 50% is now done in the ASC.
Yeah,
right.
I got you.
The interesting
that's probably the trend for most places.
Yeah, it's ironic that CMS is still waiting out on total hips. It is tough because there is a very narrow window of making any money on a Medicare total knee, right? And there's been a lot of calls for, at least in our institution, we only get $8,200 to do a total knee. So, it's a tough thing, especially when you have some overhead. It's a tough thing to be able to do.
Yeah, I guess my retort to that would be you don't get anything from the hospital.
Yeah, for sure. Yeah. Well, I think we got to be respectful of Doc SF and and the time that we've utilized today. But Craig, I want to thank you for an awesome discussion on outpatient joints. I
learned something as always. Thank you.
This is fantastic, and thanks to everyone for joining in. I hope you learned something about outpatient joints, and we're going to turn that back over to Doc SF. So everybody hold tight, and we're going to go on to the next session. Thanks, Craig.